Okay, so it's a great pleasure to be here, and particularly talking to patients, because at the end of the day, the main point of everything that we do has got to be making life better for the patients we're treating. And I think for me, over the last few years, as I've moved from being a general vascular surgeon to more and more being involved in the treatment of post-thrombotic syndrome and DVT patients, it's become increasingly apparent what a devastating impact deep vein thrombosis can have on individuals' lives and what potential we have to try and make people better. So post-thrombotic syndrome ultimately is a constellation of symptoms that get referred to as various sorts of names. You have post-thrombotic syndrome, or PTS, as a lot of people will know. It can also be called phlebitic syndrome. There is a venous insufficiency syndrome, venous stasis syndrome. So there's a number of names that get applied to the same condition. And ultimately, it's a group of symptoms and signs that patients suffer from. Symptoms is what you complain of, and signs are what we find when we examine your leg or your arm or whatever part is affected that cause damage, that are as a result of damage to the vein secondary to a blood clot that's formed in the past. So there are really two sort of components of this. You get acute deep vein thrombosis, or when the blood clot is recently formed, and that's a big sort of swollen leg that patients will come into clinic with. What we're predominantly aiming at trying to treat at the moment is those patients with extensive clot that blocks their whole leg. And you obviously have the long-term complications of this, which we call the post-thrombotic syndrome. And these sort of pictures represent somebody who's got the skin changes of ulceration that can come from having extensive deep vein disease. And in the picture on the left-hand side of the screen, you can see the sort of darkening and pigment changes in the skin that you get from blood leaking out, which is under pressure over time, which we call hemosiderin deposition. And all of these are a consequence of long-term high pressure in the venous system. We try and, at the moment, have come to a form of trying to classify patients for what disease they have. And a number of you may have heard of the CAP classification. Effectively, what this is a consensus statement to try and work out how we could put patients into groups to understand the condition a bit better. The C refers to the changes in your skin. There's etiological and what's caused it, anatomy where the clot is, and what we think might be the underlying condition, the driver for the problem. And there's also this score called the Vala Scale, which any of you come and see us in clinic now with post-thrombotic syndrome. We use as a basis for benchmarking how bad your symptoms are when we start off, and for monitoring any changes that we may see over time. All of these scores have been developed over the years, particularly from physicians, to monitor responses to treatment. And we're really working quite hard to try and make these better and more appropriate to the patients that we see at the moment. But you can see from the scores, particularly the Vala Scale, that there's a lot of features that can come from post-thrombotic syndrome. And what we do with this score is we ask patients to rate the feelings, the symptoms that they have on the left of the right of the screen, on a scale of 0 being none to 3 being severe. And that way we can get a sort of a score of how bad the post-thrombotic syndrome is. One of the things it doesn't include is ulceration, which obviously if you've got an ulcer, we immediately call that severe. And it also doesn't take into account a symptom called venous claudication. And a lot of the young patients that I've treated have been unable to walk or exercise after their DVT, and they may not have a huge swelling in their leg, or the pain may be manageable, but they just can't do any exercise anymore. And we've had a few people who used to be triathletes who come in now unable to even walk up a flight of stairs. So we all know DVT is common. You're all here in this room because we know that a lot of people get thrombosis. 1/3 of DVTs that occur are going to be iliofemoral, which is from the groin upwards. And those are the ones that cause the most severe damage from post-thrombotic syndrome. Up to 60% of these patients who have iliofemoral DVT, depending on which bit of research you read, will get post-thrombotic syndrome. And 1 in 1,000 people in the UK a year get DVT, and 1/3 of those will get iliofemoral DVT, and the numbers in the States are about 330,000 people a year. So if we look at how important this is, I'm a vascular surgeon, and traditionally the focus of vascular surgery has been treating people with aneurysms. So aneurysms have a lot of focus. Every single vascular unit you go into in the country will offer you treatment for your aneurysm. There's a national screening program to look for people who've got aneurysms, and there's a lot of attention and money spent on treating aneurysmal disease. For example, patients with complex aneurysms can have a branched or fenestrated graft, which is funded by the NHS at the moment, and those cost in the region of £70,000 to £80,000 just for the stent graft alone. So if we look at that and compare it to what we're doing for DVT and post-thrombotic syndrome, you can see that there are more people suffer from DVT with a more devastating effect in terms of mortality and death, and affecting a younger group of patients where the population have still got 60, 70 years potentially to live their life with the symptom. And yet, if you go into most vascular units in the country or most hospitals, the answer you're going to get for your PTS is wear stockings, there's not much else we can offer you. So I think we've got a long way to go to trying to address this discrepancy between the kind of things we treat. So how do we prevent it? Well, the obvious statement is don't get a DVT in the first place. And if you focus a lot of the attention quite rightly on VTE prevention, and we stop people getting a blood clot, we're going to stop them progressing to having all these horrible complications of post-thrombotic syndrome. If you do get a DVT, and we know we can't prevent every single DVT, and we know we're still fighting a battle on that front, we have to manage that. And that can be medical management, by which we mean anticoagulation and stockings, or it can be management with the newer techniques that we're trying to develop. In particular, in the early phases, we've got to try and bust the clot up to get rid of it as soon as we can, to try and preserve as much of the normal vein as possible and restore function as quickly as possible, which will help prevent post-thrombotic syndrome later. And of course, we're now developing more options to treat patients with post-thrombotic syndrome. We've had a blockage a number of years ago, and we can try and improve the circulation to make that better. Medical management essentially consists of stockings, and I try and make a number of our trainees do now is put these stockings on and wear them for a period of time. So if you're wearing class 1 compression stockings, you can probably manage those, but class 2 and particularly class 3 are quite difficult to actually wear for any length of time. And if you've got a leg that is damaged, it makes that part of management quite a lot harder. The evidence now on stockings is actually becoming more conflicting. We used to believe completely that if you put people into stockings right at the very beginning, you'd stop the post-thrombotic syndrome. But a recent randomized trial that was published last year, although the trial has been criticized to some extent, as all trials do, suggests that stockings may not make any difference in post-thrombotic syndrome. And that came from a very eminent researcher in this field, Susan Kahn. We know that anticoagulation early and appropriately will reduce it, and if you try and get somebody moving as soon as possible, that will help. But at the moment, the main problem with anybody who presents with DVT, and I've just seen a patient in my clinic this morning, is a classic example, is there is no real follow-up for these patients. So you may go into a hospital, the management is very varied. So some hospitals, GPs are now managing DVT, it's been taken out into community. In some places, a purely nurse-led service. In some places, it's managed by hematologists. But actually, the main focus has always been to diagnose a DVT, get you onto anticoagulation, and that was kind of the extent of involvement in managing DVT, largely because we'd all felt that there wasn't much more you could do apart from that. And the main focus of all the trials and studies on anticoagulation has been recurrence of DVT and, to some extent, recanalization of the vein. But we know that if the vein recanalizes, in other words, a channel opens up through it, that doesn't imply that the vein is back to normal. It just means there's flow in it. And that can mean anything from a completely normal vein to a vein that is horribly scarred and doesn't actually function in the way that it should, even if there's a degree of flow going through it. And I think one of the main things that we get as medics is this concept of the negative feedback loop. In a decision we make today, telling us that what we made was bad and we need to try and do something to improve it. So if I see somebody with an aneurysm or somebody with a blockage in the arteries in their legs, if I don't get the treatment right, there's a very quick response to that. The patient with the aneurysm ruptures and dies, and they die. Or the leg with an arterial blockage, they lose their leg and you're amputating the leg, but that process takes place over hours. So you have a very quick and immediate feedback to say your treatment isn't working, you need to do something different. With post-thrombotic syndrome, it takes at least 6 months for that to develop, and by which stage you're not necessarily seeing the same person who treated you in A&E or the same person who started your DVT program or anything else. So for physicians, they're not getting a cycle of saying what we're doing now isn't working as well as it should for our patients, and you lose that process of follow-up, which I think is one of the drivers and the stimulus for change that we don't have. There's now a lot of evidence for catheter-directed lysis as a treatment option for patients with acute iliofemoral DVT. There's various papers that have been published, and last week we just finished a major vascular conference where we had an entire day for the first time devoted to discussions about treating lysis and trying to improve how we're offering treatment to patients. So the principle really is that these two sort of papers were published in the last few years, which provide randomized evidence that if we aggressively treat iliofemoral DVT in the beginning, as soon as we can, within 2 weeks, with clot-busting drugs and try and restore the system to normal, you can reduce the rate of post-thrombotic syndrome probably from in the region of 60% down to about 10% or less. And there's certainly some groups who have got patients that they've followed up for a year where there is no post-thrombotic syndrome in these patients, which is certainly a big step forward in trying to prevent it developing in the first place. So the idea really is that we place a catheter into the vein, which is placed in over a wire, and we run clot-busting drugs through that over a period of a couple of days, and we're trying to reveal an open vein at the end. And you can see in this patient, the vein is opened up, but up top here, there's a blockage, and the blood, instead of flowing straight up through there, is coming down through the side and up the other side. And that syndrome that this patient has is called May-Thurner's or Cockett syndrome, which some of you may have read about or heard about. We call it Cockett syndrome here at St. Thomas's because Cockett was a surgeon who worked here and described it. In many places called May-Thurner's because, like a lot of these things, it is described simultaneously in multiple places in the world, and May-Thurner was in the States and Europe. Effectively, what it is the main blood vessel coming down to supply blood to your legs crosses the veins that are draining your leg, and at this point, the artery sits above the vein and compresses it between the artery and the spine, which is right behind it. And over time, that blockage can really scar up and form a narrowing. It's this that we call May-Thurner's, but there are other places, like here, where arteries can cross the veins and cause narrowing and blockages. So in a number of patients that we treat with lysis, probably about 80%, we'll find one of these blockages at the end, or what we call May-Thurner's syndrome, and the idea then is that we need to stent that I'll go back to try and treat it. So if we look at some surgery, this is what we used to do in the past, which is an operation. You can see how big the vein is. That's the vein, the normal vein beyond it, with that artery really compressing it very tightly. This is an MRI scan that shows the same thing, and that's a CT scan where you can see there's the spine that's sitting just behind the vein. There's the artery, and the vein has to travel between that really tight little gap in the back over there for the blood to flow out of the leg. And this is one of the main problems that causes it. I don't know if you can play these videos for me. If you scroll onto them at the bottom there, if you just click on that. So this is the venogram of the same patient at the end, and you can see how the blockage there as it played through has gone completely. I use this system called intravascular ultrasound, which is a very new technique which allows us to see extremely high detail into the veins. You can possibly try and play the video on the left as well. And what this does is gives us an ultrasound scan from inside the vein that can show what's going on. And you can see there's a stent sitting inside the vein that we've put in that is keeping the whole vein open. And in that particular patient, we've removed the May-Thurner's blockage, and that certainly confers the chance of a much better long-term success for these patients. Most of the data we have comes from a chap called Peter Neglin and another chap called Suresh Raju, who ran a service and really the pioneers of venous stenting and treatment for these patients. And they've got the longest term data. This is their data out to 72 months. And you can see here, these are the sort of lines showing that we start off here with 100% of stents working, what you can expect in acute DVT out to these sort of time frame. This line here is the patients. You get a sort of drop-off of people who need to have a second procedure or a third procedure to keep the stents open. So it's by no means, a stent is not a panacea. There's a number of things that go on in patients, and what we're doing is trying to work out how we can make this all better. And that's the point of being in a center like this where we've got a lot of people who are doing it. So you can see the difference between these two graphs. If we treat patients in the very beginning, this is what the lines look like. If we have to wait and we don't get the chance to do an acute treatment, the lines look like this. So you can see it's much, much harder to treat somebody who's got post-thrombotic syndrome, who has had what we call chronic occlusive disease, than somebody when they've got fresh clots in the beginning, when we can open the vein up as early as possible. So the whole driver of this has got to be stop blood clots in the first place. If you do get a blood clot, try and treat it as quickly as you can, and try and reduce the number of patients that are getting out to this point where they need something done in the long run. This is just some data on our early results when we first started a service. These patients I've chosen because they're out more than a year, so we've got a bit more robust data on them. But this was the first sort of group of patients. We had 24 patients with acute DVT and 26 who came with post-thrombotic syndrome. And this is kind of what they had We don't pick up thrombophilia in all of the patients, probably about half in the complex group. And there is a number of patients, obviously, who've had a pulmonary embolus at the same time as they've had their DVT. With the acute treatment, we open up the vein in 100% of patients. We put stents, about 3 stents in all of them on average. 1 patient had a bleeding complication, no patients had DVT. And in this patient who died, they had a malignancy, and we were treating their leg with an underlying cancer, which is a very common cause of blood clot, and they died from progression of their cancer rather than the DVT. You can sort of get these results. The name at the top here, over the last few years, we've seen an explosion in development of new venous stents to try and help us treat this disease. In the past, we used to use arterial stents, which don't really work. We've got a lot of new technology, and the companies are really very keen to invest now in trying to drive this forward, which is a sign of recognition of growing interest in a disease if there's commercial interest that starts to come. So these are new dedicated venous stents, and you can see here we've got out to reasonably good results with very high patency rates with patients with iliofemoral DVT, which comes with the work. The key for all of you as a group of patients, though, is it's not necessarily a one-off thing. You can see here that a number of people need to have more than one operation to keep it working. It's not a quick fix solution by any stretch of the imagination. And the same thing in the post-thrombotic syndrome. We've opened up the majority of the veins. A couple of patients have needed reintervention again in this group as well. Of course, if stenting fails, there are options with operations, and this is a patient who had an ulcer from post-thrombotic syndrome that I reconstructed his veins, and we use bypass grafts to go through the veins. This is a much bigger thing than stenting, and the important part about all of this is that you have to have very careful counseling in clinics before. We've got to talk through all the risks and benefits of surgery and intervention before anybody proceeds to do it, because it's not a quick fix and it's not straightforward in every single patient. These are some really new pioneering techniques that a colleague of mine has sent me these photographs from Italy, where he's reconstructing valves in patients. So you can see the valves in your leg when they get damaged. This is a very, very fine structure. They work like sails on ships in the wind. They move very slowly, and it's extremely difficult to rebuild the valves in your legs. I mean, the irony for me is I spend a great deal of my time treating people with varicose veins where we're trying to block veins off, and the rest of my time trying to treat the deep veins where I'm trying to keep them open. And the ones that I want to block off don't always stay blocked, and the ones we want to open don't always stay open, but that's the nature of treating patients. The final word on all of this is fundamentally none of these treatments, none of these interventions, and none of anything works without a proper team. And I'm extremely fortunate here at St. Thomas's, and one of the real reasons for coming here from St. George's was to join a fantastic team that Professor Hunt leads, which is engaged with the hematologists, the vascular surgeons, interventional radiology, nursing staff, and of course the patient in the midst of it all. If you don't work together and you don't try and combine all your efforts and you try and do this by yourself or individually or on a tangent, you will never get the results that you need. And like this British cycling team, I think their best contribution to all of us was the concept of marginal gains on each little thing. If you do each little bit just that much better, you'll make a massive overall difference to the results. And that's what we're trying to do here in getting options to patients for treating post-thrombotic syndrome. Thank you very much.
Thank you very much, Stephen. Now, who's got some questions to ask? This is now your chance to ask those questions. Right, here we go.
Should you have a referral to a hematologist, and when should you have the referral, and why should you have the referral?
After having a blood clot?
After having PEs.
I think that it's vital for everybody who has had a blood clot, whether it's a DVT or PE, to be seen by a hematologist at some point. And I think the referral should be early rather than late. We try and refer everybody straight away to a hematologist, and I think that's what I would advocate.
I asked my consultant, I've only had one consultation since I've had bilateral PEs, and I asked about a hematologist, and she just curled her lip up and said, well, why do you want to see a hematologist? And I said, well, I don't know anything. I've just heard people say they've gone to a hematologist.
Yeah, I mean,
to see if you've got a gene or whatever.
I mean, I think Professor Hunt's going to give a talk on thrombosis and the complications later on in the day, which will explain a lot of that. But I think for us now, we know that treatment has been uncoordinated and probably to an extent poor in the community. And unless we drive a change of professionals who have a specific interest in something, and that is hematology allied with the other disciplines like us who are now starting to treat this, we're never going to improve things. And I think, to me, it's absolutely essential that you get seen by hematologists with an interest in it as
So I should
soon as
insist
possible.
on seeing one. I'm seeing it tomorrow.
Yes.
So I would say, as a haematologist, that the average haematologist has got no interest in blood clots at all.
Yeah.
And who you want to see is an expert in thrombosis. So sometimes they happen to be physicians, that they just do general, but they see an awful lot of thrombosis. And then some haematologists specialise in thrombosis and bleeding, and that's the other type of haematologist you want to see. But the average haematologist looks after people with acute leukemia and lymphoma and things like that, and they don't have much interest in blood clots. You have to be careful. It's probably better to get a name and say, can you get me referred to this person, rather than anything else.
I agree with that.
You said that stenting is an option for venous thrombosis. My vascular surgeon said that he can't stent in brachial vein because he says before I've put a stent in, that it will be clotting again. Is that true?
So I think the interesting thing about this is where I will in my entire training with this, we had this concept that venous stenting was bad and you shouldn't do it. And I think that's in a large part because the technology was really poor and our understanding of the disease, we approached it like we did arteries, and veins are completely different. So for example, if you stent an artery, you treat the worst bits of disease and you leave the rest, and generally that's okay. In veins, you have to look for all of it. So I think the answer is that venous stents can block off, and I showed you the data there that we have a patency rate of, with stents that don't block, of probably about 80% to 90%, which we're improving all the time. But it's not a venous stents all block is not a statement that I'd agree with at all. I think we've got a lot of success now in treating patients.
Okay.
Okay. I feel very bitter about the treatment my daughter received. Subsequently, they decided she'd probably had a PE that was followed a few months later with an extensive DVT. When our GP tried to get her admitted to hospital with a suspected PE, she got sent home in the middle of the night. It was only later, when we asked to be referred to a different hospital, that they said, oh, we think you've had a PE as well as a DVT. The latest decision, which was in December, was that there was still a blockage from the DVT, but they weren't going to do anything about it, and she had to take warfarin for life. She was 22.
Yeah, I think that's increasingly the sort of stories we're encountering, and I think I would say, I would almost start to use the word crusade. We're on a bit of a crusade now to start changing attitudes about this. Those sort of solutions for 22-year-old patients whose entire life has been devastated are not good enough. Even if we can't end up offering treatment, you need to provide people with options, and you need to be able to talk through all the possible things that you can do, and need to provide people with support, whatever else you do. And I think that sort of experience is the kind of thing we have to change. We can't have that going on.
But where does she go next? I mean, she's effectively, she's been sent away from hospital.
So there's a concept of patient choice, isn't there? So patient choice now is you can go into your GP and you can ask to be referred to whomsoever you choose who can treat you, and your doctors can't not refer you on that basis. So the idea with this is you want to be seen by people who know what they're doing in treating disease. So we are obviously a centre who do it, and we can certainly help you. And if you want to be referred into our team, that's not a problem. You just have to ask your GP to do it, and we can see you. But there are other centres we are training up around the country now to do this. So we can give you advice on. I can give you advice on people who are locally based who can help as well.
Thank you.